Okay, that sounds great. All right. Oh, wait. All right. Good morning, everyone. I'd like to call us to order. So the House Subcommittee on Behavioral Health is here this morning. Would Madam Clerk please call attendance?
Chair Braybeck.
I am here.
Representatives Arbit. Pahutsky.
Here.
Glanville.
Present.
Edwards. McDonald. Present. Reingens.
Here.
Schmaltz.
Here.
Hoadley. St. Germain.
Here.
Thompson. Madam Chair, you have 7 members present. You do have a quorum.
Thank you, Madam Clerk. I appreciate it. Representative St. Germain moves to adopt the minutes from the September 14th meeting. Without objection, the minutes are adopted. So this morning, team members, thank you. Oh, it's okay. Sorry, folks, I forgot my glasses in the car this morning, so now I can see. Thanks to our clerk for finding me a pair of glasses. We are a team. So this morning we have a number of bills that are really addressing some of the issues that we have around the opioid addiction crisis here in our state. And I'm grateful for the work that's been done on them. So first up, we are going to hear testimony on House Bills 5077, which is Vanderwall bill, and 5078, which is a Reingens bill, and they are here to testify. And joining them is Ken Huvelman as well. Good morning.
Well, good morning, Madam Chair and
Good
committee.
morning.
Appreciate the opportunity, and guess what? I got to pull mine out. Because if you don't, you sit here and you go, my arms are no longer long enough. You might have to hold my my script. But to be honest with you all, thank you for the opportunity to be here today and really discuss some bills that are very close and dear to what I've been working on for several years here in Lansing, and I believe the committee will agree. It's House Bill 5077 and a companion bill 5078. And I really do want to say thank you to Rep. Reingens for her work on this important issue also, and we hope that you feel the passion that we have. But currently, Michigan departments and agencies are allowed to purchase and possess life-saving drugs such as Narcan. In certain Michigan departments or agency employees are permitted to carry and administer those drugs to those in need. In essence, these bills allow certain Michigan departments or agencies and employees to distribute life-saving drugs to any individual. As many people already know, the difference between life and death when dealing with a drug overdose is mere seconds. Thankfully, certain dedicated agents and employees are able to administer Narcan and other life-saving drugs if this situation arises. Allowing those agents to distribute doses to those who may need them in the future for themselves or others is critical. Access to doses and the ability to store them in personal spaces could save valuable time and very well may be the difference between life and death. Importantly, this bill does not require the distribution system regardless of need. It simply adds distribution to any individual to the list of permitted activities, including possession and administration. Also, this bill updates the civil liability exemption for department and those employees or agents to include exemption from liability stemming from distribution. Again, I am thankful for the committee and their consideration to this important issue. I look forward to working with you and am happy to take any questions you may have after a couple of other folks speak. So thank you again for the opportunity to be here. I really, truly appreciate it. Thank you.
Thank you. Thank you, Chair Braybeck and members of the committee for having us here today. I'm very excited to be working with Rep. Vanderwall because we have talked about opioids as an issue in our state for many months now across multiple committees. So I think folks know last year in the U.S., over 100,000 people died of opioid overdoses. And here in Michigan, it was 2,993 Michiganders who died of opioid-related overdoses. These bills that we are proposing today will help prevent that tragic loss of life. HBs 5077 and 5078 are simple bills. They will expand the group of people who are legally allowed to distribute naloxone to all government agencies. And right now, government agencies can only administer naloxone individually. And we want to make sure that we can get more naloxone in more hands across our state. It will help us prevent overdoses and deaths. Right now, we have seen that states have enacted this naloxone access laws and have them expanded to the full extent that they can be. Opioid-related deaths are reduced by 14%. So thinking of those 2,993 Michiganders who died last year because of opioid-related overdoses, we could have saved 419 Michiganders, moms, dads, siblings, if we would fully expand all of our naloxone laws. So the state of Michigan, this year alone, has already ordered 215,000 naloxone kits. So it's really imperative that we get these in the hands of everybody that can possibly distribute them across the state. So thank you, Madam Chair. I urge a yes vote on HBs 5077 and 5078. I'm also excited to be joined here today by a longtime friend and colleague of mine. We actually graduated in the class of 2000 together from high school, but now we both have worked in the behavioral health space. So I'd like to introduce my friend and colleague, Ken Huvelman.
Thank you for allowing me the opportunity to speak today. I did want to speak as an agent and as a distributor of naloxone. So I work for an outpatient substance abuse treatment facility. We also operate a state-funded quick response team. And in 2020, we decided to begin doing naloxone education and naloxone distribution. It is one of those things that we've operated in a somewhat gray area. I can say this year alone, I've ordered 2,000 kits. This month alone, I've placed 2 orders for a total of 800 kits of naloxone in this month. I go on to an MDHHS portal. I tell the state where I'm going to distribute it, my intents to distribute it, who I plan to distribute it to. And I do this once to twice a month, and then they deliver the kits to our office where we then distribute. We use the MDHHS strategies to distribute it and place it in the locations that create easy access. This is one of those where if we follow the letter of the law, I'm acting outside the scope. It is not something I'm legally able to do, but it is something being urged at settlement fund meetings, Michigan Association of Counties, the Wayne State Center for Behavioral Health and Justice that's supplying naloxone vending machines to communities. Harm reduction providers like ourselves and others across the state are purchasing boxes to make them publicly available. Pushes to have these placed. I believe there's work going on with the Michigan Department of Transportation to have it at all state rest areas. These aren't generally stocked by state employees. These are harm reduction groups like Port Huron Odyssey House, the Greater Flint Health Coalition, Families Against Narcotics. So it's one of those that while this is the mission of our work, it technically places us outside the scope of the law. The ability for agents or organizations allowed to order it from the state, being able to distribute it would be greatly beneficial in us. I can say that in St. Clair County, since we've started this initiative, in 2021, we had 66 drug-related deaths. In 2022, we had 38. That's a 49% decrease in drug-related deaths in 1 year when we have spent 2 years, 3 years pushing this naloxone, this life-saving medication, into our community. I can't say that's the reason that less people are dying from drug overdose, but I would assume that that's a part of what's preventing unnecessary deaths. Thank you.
Thank you all for being here this morning. Colleagues, what questions do you have for the folks here before us? And Rep. Schmaltz.
Thank you, Madam Chair, and thank you for being here. I think this is wonderful. We do need to help save lives. Can you just recap again? Government agencies have the authority to do this now, and how does this expand again? Just recap that.
So technically, the standing order that exists in Michigan is for pharmacies to distribute naloxone. So people who are not pharmacies and agencies who are not pharmacies can't actually like get a box of this and distribute it on to the next group or give some to individuals. Now, like a police department, the officers can administer it to somebody to reverse an overdose, but they can't like give them an extra one to take with them, right? Like, so this is clearing that up and making it explicitly legal.
Thank you.
And I appreciate the question, Representative. It also came, through my committee last year. We continued to have different organizations that would come through our libraries. It could be, just different public settings, and they were coming through. And we really realized that we're not going to, overall, we want to make sure we make a difference. And these are the opportunities, but it also clears up some of the liability that groups like this gentleman are involved with to make sure that those areas that are gray are no longer gray, and we're actually moving forward and doing the right thing for the right reasons.
Great. Thank you.
Representative Glanville.
Yeah, thank you for this important work. I'm curious how I heard you describe the process. So you have to request these kits from DHHS, is that correct?
Yeah, so to order kits, if you go through the state's website for the naloxone orders, it's just a PDF that is very filled out. It goes to MDHHS naloxone request folks with its own division. So it's a request to have those delivered straight from the Michigan Department of Health and Human Services.
So how, is there a mechanism in the bill or in the legislation for alerting agencies who maybe haven't been doing this work? I'm thinking schools, maybe libraries. I know some of them have engaged in this or have been talking about it, but for agencies who are maybe unaware of the process or that it even will impact them, like, are we doing something to notify them?
So this bill doesn't mandate that or require that in the language of the bill. This is something that the department would do and has been doing, actually, for years, that the department has been purchasing large quantities of naloxone and distributing it through this online portal. They have been working with community groups. Now, if we expand the number of groups who can do this, I'm sure that word will travel fast. And even if it doesn't, MDHHS will be out there telling people and notifying folks that this is possible. I will say this bill also allows public entities to directly purchase naloxone themselves if they want. It doesn't have to only go through the department. So the department does purchase naloxone that it then can distribute, but this would allow for those other kinds of public institutions to get it themselves if they want anyway, outside of the realm of the department.
If I may, Chair. So now that you're saying that, I'm just curious, and I appreciate that, just making it easier for people to get, but would that somehow disrupt data that we're collecting if it's not going through the department? Are we going to lose out on some, would we be able to then demonstrate that this works, or, what's
So
the impact?
the data is a really great question about how naloxone is already distributed and used across the state, and reporting of the overdose reversals is also somewhat difficult to happen as well. So I would say if there are public entities like libraries or schools or universities or something that would then purchase directly their own naloxone from some source, they could voluntarily report that to MDHHS. If there's a need, if we feel like this might be a need, we could possibly mandate that. I think this is something for the administrative department to work out more so than like a legislative law for us to work out per se. I think this is more of a regulatory area. So I think it's a great question, and I actually am curious to talk to colleagues at MDHHS about that.
And if I, sorry. Is this only, and just to clarify, is this only for government agencies? I'm just wondering if there might be, concert venues, bars, that sort of thing where individual proprietors might want to have this on site. Is that a possibility?
This opens it up
Okay.
for basically anybody that feels they have a qualified person, that's somebody that's trained. Really what it's done, I don't see anybody really going outside the DHHS system because they're not going to pay. They still want to go through, but any organization now that wasn't on the current list had to go through this same process through committee hearing to be able to
Okay.
take this. And we really want to eliminate, we want them to go through the department. We want them because, number one, we're already providing this product. We want to make sure that we're getting it in the hands. I'm sure we already have that product in concert venues. We just don't know that because they're being carried by the personnel that is there. But there's so many different places that we could be to make sure that we have an opportunity to save somebody's life, and we want to make this simpler.
Okay, thank you, thank you, and
bet.
thank you for allowing so many questions.
They were wonderful questions. Can you talk about where we've seen this in other states? And Rep. Reinkens, you talked about the 14% difference that this makes, and that's incredible. If we can save those lives here in Michigan. How do these bills compare to the expansion in other states? Are we on the kind of the side of being more towards as expansive as we can? Is it just kind of a little step up? Can you kind of put it in context for me?
And if you have any additional information, I would say that Michigan is already a state that allows for the distribution of naloxone and the widespread use of naloxone, and I think we should be proud that we were a state kind of in the forefront of that. But as Rep. Vanderwall said, over the years we've heard that there were some things that weren't completely clarified. So this is a small clarification that definitely will help, but it's not going from no allowed naloxone to all of a sudden it's allowed. It's just saying it has been allowed. We're just clarifying in case you were worried that it is now fully allowed for public entities. In case either of you want to add.
And I could say for that, so I think it's been since 2016 that the standing order for possession and administration of naloxone has been in place. It's been a prescription medication until this year when it was changed federally to over-the-counter. That change was not because of states like Michigan. Michigan was already ahead of that. This was for some of those other states that did limit possession or placed it behind a pharmacy desk anyway. And it is part to the other one is the cost would be prohibitive for most organizations to purchase themselves, and there is a broad scope through that portal. You kind of drop down and then select which organization you look at. In increasing this, because our pharmacies carry it, and I can say in our community it's ranging from $35 to $55 to purchase from a pharmacy without insurance, and about $10 to $15 with a copay. So just increasing the free access by making it more comfortable for us to distribute. Like I said, we have 215,000 orders. I don't see that being the pharmacies that are ordering that. There's already community-based organizations that are doing this. It's just protecting us from liability ourselves.
I can remember sitting back in Washtenaw County when I was a county commissioner, sitting on public health, and we had the ability to be able to get naloxone, and have our sheriff's deputies carry it. And we had to do the whole okay, well, how do we get that? The sheriff can't get it directly. How do we figure all this out? And so I was really happy that Michigan was on that forefront trying to figure that out. But there were some real roadblocks for folks who are in the community wanting to do this work. And so I'm grateful for your bills and grateful that you're here testifying. Any other questions on these two bills? Okay. Thank you so much. All right, just so now we're going to hear testimony on House Bills 5178 and 5179, both Rep. Reinkens bills, and we have several folks here to testify. First up, we're going to have Rep. Reinkens, and then I'll introduce the following people after you're done.
Great. Thank you again, Madam Chair, and members of the committee. I am excited to be able to testify on these two bills, which deal with our state's drug paraphernalia laws. So right now in Michigan, test strips, like fentanyl test strips, which we've heard about in the news, those are technically illegal as drug paraphernalia. In addition, so are hypodermic syringes. Those are considered drug paraphernalia in our state drug paraphernalia law. So these two bills, 5178 and 5179, will amend our public health code to change those definitions to make sure that these public health devices are actually able to be used for public health purposes. So HB 5178 empowers individuals and localities to create syringe service programs, or what I will be calling SSPs, if they so choose. SSPs are community-based prevention programs that meet people where they are and connect them, the folks who use substances, and connect them with comprehensive resources and care. SSPs offer many services, including coaching and connection to substance use disorder treatment, disease testing, overdose prevention training, providing vaccinations, and helping participants in accessing medical and other social services. You'll hear much more about these programs and services from those testifying after me today, including firsthand accounts of using and working in SSPs. There are currently 97 SSPs operating in 53 of Michigan's counties, which have seen 167,573 participants go through these programs from October 2018 to June of 2023. HB 5178 would allow these to be expanded statewide and help meet the needs of Michiganders who are currently unable to access some of the available treatments. The CDC found that of all states, Michigan was ranked 5th in the number of most vulnerable counties, vulnerable to the spread of disease amongst people who inject drugs. So we are the 5th highest state in those counties. And those counties are largely in the northern rural parts of our state. Expanding SSPs into those counties would tremendously reduce infectious disease transmission and harm in those communities. These programs, SSPs, have been shown to be effective at reducing the spread of diseases like HIV and hepatitis C, and have been very effective in getting folks enrolled in substance use disorder treatment, and of course, reducing the number of overdoses and deaths. And according to Michigan's Department of Health and Human Services, SSPs in Michigan have reduced HIV and hepatitis C prevalence by as much as 50%. And SSP participants have been 5 times more likely to enter into substance use disorder and recovery services than people who use opioids who are not in a program. 5 times more likely to be able to get treatment. Most importantly, they save lives. In 2020 alone, the lives of at least 2,000 Michiganders were saved at SSPs through the administration of naloxone. And I will say, colleagues, that this is personal for me. 20 years ago, I got my career started by working in an SSP in Washtenaw County. Baby Carrie was going out on a van with my colleague Lamont, and he knew everybody that came to the van. We had a van out at a party store in a part of Ypsilanti, and everybody that came up, he knew them by name. They knew him. He asked about what they had done in the last week. He knew them. They knew him. And so many of those folks, after years of coming, chose to get into treatment because they knew that Lamont was just there to help keep them alive. And Lamont was there to help them realize that there is somebody who you see every week who is not judging you. He's here to help you. He will help you stay alive and get you what you need. And it was a real honor to learn from him about how being in the community, listening to people, meeting them where they are, not just physically, but in the course of their life, and being non-judgmental is really important to helping build that trust to help people get the health services that they need. So here in Michigan, we have the governor's opioid task force. We have an opioid advisory commission out of the legislative branch, MDHHS, and even the governor's team have all called for SSP authorization. Joe Coyle, the director of the Bureau of Infectious Disease Prevention at MDHHS, recently said, "We believe that sterile syringes should be available and accessible to any person in Michigan that injects substances." This was at the National Association of County and City Health Officials Conference, not too long ago, the national conference. So there are already 33 other states and DC who explicitly have passed laws to authorize SSPs, and I think we should be the 34th. In addition to HB 5178, 5179 would remove testing products such as fentanyl test strips from the state's definition of drug paraphernalia. This would enable people who use drugs to test their drugs to ensure they're not contaminated with fentanyl, and this helps reduce the chance of accidental overdose and death. Similar legislation has recently passed in South Dakota and Pennsylvania with bipartisan support. We know that any loss of life is tragic, but it is especially tragic if it can be prevented. Both HB 5178 and 5179, if passed, will go a long way in reducing the number of opioid-related overdoses and deaths, and we'll see more Michiganders struggling with addiction being able to get into treatment and reduce the spread of diseases like HIV and hepatitis C. Let's reduce these deaths together. I urge you to vote yes on 5178 and 5179. Thank you.
Thank you, Rep. Reingans. Members of the committee, Rep. Schmaltz.
Thank you, Chair. Thank you, Rep, for your testimony. I just have a couple questions. I know some opponents of this will say that this promotes drug use. That's one of the questions. And also, when you talked about how when somebody comes due and gets a needle, then they're more apt to get treatment. Do we have any statistics on those who have been given these needles and then have a fatality?
I'm sure that exists. I can't think of off the top of my head at the moment.
I was just curious.
Yeah,
about
I
that.
mean, I think part of the issue that's happening now is that some drug sources are being contaminated with fentanyl that people don't expect, so it's higher than their tolerance. And I think that's part of why it's so important to make sure test strips are not illegal. And I think that in my experience working with people who use drugs, they know their tolerance, and they're not using in a way that would result in a fatality from the drug itself. What we're focused on here today is making sure that when somebody is using, that they are not also getting an infection from hepatitis C or HIV, which are both bloodborne illnesses, which can be transmitted through blood exchanged in a needle. So I think this actually, I don't know numbers of fatalities in part because the focus here is that these programs save lives to make sure that people don't get the infectious diseases.
Yeah, I was just curious about that. Another thing is when the needles are given out, they're not actually injecting there, right? The needles are given to them.
You know, since we have 97 SSPs in the state, I mean, I don't think any SSP bills itself as a safe use site at this time. But I have not been to every single SSP, so I couldn't say. The intention is to distribute supplies for folks. And
Yeah, I guess my question was what happens to these needles, because we end up having problems with these needles being in bathrooms in Burger King or different places.
I would say
and,
that I don't think that
kids-
that's a SSP leaving a needle there.
No, but when they're distributed out to people and then these are left places, then you have problems with kids getting a hold of them. That's just an issue that some have raised.
Yeah, so I guess just to be really explicit about how this works, when a person injects the drug, there still remains a tiny bit of that drug left in the needle. And to be actually in possession of that needle that contains a trace amount of that drug, you are being in possession of a classified drug. And that's illegal unless you're, a person who uses that in your medical field. And so I think a lot of people are worried about where do they return these needles. If we have SSPs in more places, we'll be able to recapture more of those used needles and make sure, and once that is legal in Michigan, to be able to have this all across the state, I think we'll actually recapture more needles because people will want to return them because they'll get clean ones. So
I just want to be
hear
clear,
your
too. I
concern.
wasn't pointing out Burger King. I'm just saying different places where kids can get a hold of them. That's just a concern for some people.
And yeah, I think that these programs have been really successful in recapturing needles from the community, from what I've seen personally and what I've observed through the years of working in this space.
Okay, thank you.
Colleagues, anyone else? Rep. Pohodsky.
So you touched on this earlier, but I just wanted to make sure. The whole point of this is that people bring back used needles in order to get clean ones where they are less likely to come into contact with infectious diseases, right? Like they bring
Yes.
needles back rather than leaving
So
them.
the bill, as lawmakers, I personally, coming from the world of public health, I don't think that this law should prescribe how a program has to operate and that it is like a one-for-one exchange necessarily. I think a program can develop, the department can develop guidelines about this for programs to be established and recognized by the department, but that is the intent, is that people will be returning the needles. And that has, in fact, been borne out by what we've seen across the country.
And the other question, I don't know if you have any information about this, but do we have any stats on the decrease in infectious diseases in places where there have been SSPs?
So there are a lot of statistics about this on the national and state level. One of the things that we brought into my testimony today was that according to our own MDHHS, SSPs in Michigan have reduced HIV and hepatitis C prevalence by as much as 50% in the counties where they are existing. So that's a pretty good.
That's amazing. So I used to work in toxicology, and unfortunately, well, the first part was fortunate. There were some pill mills in the southern portion of the state that were identified because of the tests that we were getting / not getting. But then the unfortunate side of that is obviously heroin use went up by roughly 150%. And with that increase in heroin use, so did incidences of HIV and Hep C. So I'm really, really grateful for you bringing this forward and just highlighting the reality of it. I mean, yes, in a perfect world, no one would be addicted to substances, but they are. And making sure that we are doing that as safely as we can while offering resources to help people get into recovery is amazing. So thank you for bringing this forward.
Thank you.
Colleagues, anyone else? I just want to add my gratitude to you, Rep. Reingans, for bringing these. When I was in social work school, so back in the mid-'90s to later 90s, I was able to work in Boston putting together needle cleaning kits and distributing those to, or being part of the organization that then distributed those because it worked. Right? It made a difference in terms of the spread of diseases, and it kept folks safer than had they not had them. And so we know, again, this has been for decades. We know that this is a strategy that can help people and it can help save lives. So thank you for being here. I appreciate it. We have more folks to testify now. So I'd love to welcome up, we might need to pull up another chair, I'm sorry, but we have Steve Alsam, we have Pam Lynch, Kim Gannon, and, who is on, so we are not going to need, Kim is on Zoom. Dr. Kara Poland, is also on Zoom, so that's great. And I know that I saw Judge Linda Davis. So, okay. Welcome, everybody. All right, Steve, we'd love for you to start. Can you turn on your microphone? It's right, there's a little red, but you got it.
Awesome.
That's great. That way we can hear you.
My name is Steve Alsam, and I'm the Executive Director of the Grand Rapids RED Project. RED Project has provided a syringe access program since 2000 for almost 23 consecutive years here in Michigan. We are currently the largest program in the state. We directly reach over 5,000 individuals and over 25,000 visits annually and distribute and collect over 2 million syringes in West Michigan alone. We believe it's a basic human right that people have access to the knowledge, tools, information, and support they need to stay healthy and to stay alive. For people injecting drugs in our state, sterile syringes are one of these tools they need to stay healthy and to stay alive. Syringe access programs, although often framed as controversial in the news media, are really just good, solid public health practice. Programs like ours have existed for 3 decades in the United States, and over that time they've been widely studied. The data is in. I'm not going to quote the data at you. I believe you're smarter than that. You are stewards of the public good, and not supporting syringe access programs at this point in time, in this day and age, would be reckless. The bill you have in front of you does a few things. It provides needed legal protections for staff and participants of syringe access programs across the state. It allows participants of programs to not fear criminal prosecution for carrying the tools they need to protect their health. Unfortunately, right now in our state, syringe access programs experience a patchwork of legality and illegality. This bill decriminalizes trace amounts of controlled substances contained in used syringes being returned to programs. If you want people to feel safe returning used syringes to programs, they need to not fear prosecution and arrest. Syringe access programs have been collecting used syringes in Michigan for decades. We need legal clarity on this matter. Finally, it explicitly legalizes drug checking supplies. In the age of fentanyl and xylazine, people need to know what they are putting in their bodies. This is essential to protecting health. Without knowing what you are putting in your body, there's not much you can do to protect your health. This bill does a few things that we need in order to protect the health of our community. However, it does not go far enough. I would urge you to go one step further than the bill you have before you. I urge you to also decriminalize syringes and other harm reduction supplies received indirectly through programs and other sources. We know that when we criminalize the tools people need to protect their health, it will lead to negative health outcomes in our communities. We are living in the reality of that situation right now in our communities. When people experience barriers to accessing the tools they need to survive, some people will not survive. This is the reality in our community right now. Some people are not surviving. I told you I was not going to quote statistics at you. I trust you have the ability to find out for yourself. Today you have the opportunity to push forward policy that will impact the health of our community. I hope you do the right thing. I expect there will be pushback on this bill from the law enforcement community. They like to say they can't arrest their way out of this issue, but sometimes it seems like they want to keep on trying. Thank you for your time today.
Thank you so much, Steve. Next, we have Pam Lynch from Harm Reduction, Michigan.
Hi, everybody. Thank you for welcoming us.
Oh, can you turn on the? There you go.
Good
Thank you.
morning, everybody. Thank you for welcoming us here today. My name is Pam Lynch, and I run an organization called Harm Reduction Michigan. We do a lot of capacity building. We've recently been training a lot of physicians through the Central Michigan University College of Medicine and Michigan Osteopathic Association as well. So I'm here today to talk about our program. We do direct client service, mostly in the Lower Peninsula. We're based in Traverse City. I was born and raised there, and I really went back there because my mom was elderly, and that's really the reason why that's the basis of Harm Reduction Michigan. But it was interesting for me. I moved back to Michigan in 2008 from Newark, New Jersey, and I'd been doing this work for about 25 years at that point. So I get back to Traverse City, people are dying of overdose. When I grew up in Traverse City, people were not dying of heroin overdoses in that town. We have since experienced this opioid epidemic, and we now have heroin and fentanyl in every small community throughout the entire state and country, for that matter, or we wouldn't have 100,000 plus people dying, right? So I'm really grateful that this committee is willing to listen to these bills today. Pretty critical. And I want to point out a couple things. We have a PowerPoint, but I think in the interest of time and the challenges we had with the PowerPoint being pulled up, and anyways, long story short, I'm just going to make some additional points. So when we looked at the bill about naloxone, right, where Michigan's been on the cutting edge, however, in terms of this bill, Michigan's not. We're about 30 years behind. Like Boston, New York, Baltimore, places that had heroin problems before this recent epidemic. And so the data has been done. It's very clear. It does not encourage drug use, and it actually encourages public health messages. So that's the other point I like to make about these programs is people don't just come and get needles. People come and have trusted relationships with the people that work there. I'm a licensed master social worker, and I'm also a certified advanced alcohol and drug counselor. And so when people come and talk to people, like on the truck that Carrie was talking about, and in the programs that Rep. Braybeck was making kits for, in Steve's program and Linda's program, it's about the relationships that people have with the workers. And so in building that trusting relationship, they will come and get services from our programs when they wouldn't necessarily show up at the health department to get an HIV test, because they want to go somewhere where they know they're not going to be stigmatized or judged for being stuck in this behavior that's perceived as very self-destructive by society, right? So Rep. Schmaltz, when you asked that question about the people maybe dying of overdose that have gotten these needles, it's my experience in addiction work that when somebody's opiate dependent, they're going to use that opiate whether they get a needle from, for example, at the Goodwill Shelter, which is in Traverse City, our homeless shelter, they actually called us in to start helping because they had people trying to use syringes out of their biohazardous medical container. Like in their medical office, people were trying to get used syringes out of that bucket to use drugs. So it's my experience that when somebody's opiate dependent, they're going to find a way to use opiates, whether they get it from a program, whether they get it from a diabetic relative, whether they get it off the street, or wherever they get it. So that's the challenge, is that, we're trying to help people have access to sterile utilities so that they don't spread HIV and hepatitis C, and you've heard the data on how it decreases those infectious diseases. So I just want to talk a little bit more about what syringe service programs do. Different programs do different things. We had the privilege of hosting Representative Vanderwall a couple years back at our program in Cadillac, Michigan. I want to talk a little bit about that program. So we started in Traverse City, but we had people we have staff who participates in Narcotics Anonymous, and we had people that were going to Narcotics Anonymous meetings in Traverse City because they'd been sent to treatment in Traverse City, and who were begging us to come to Cadillac and start providing services because their friends and family members were dying of overdose. There was no naloxone available there, and there was no treatment there. So I know that Representative Carrie Reingen talked about the Michigan being the 5th state in the country with risky practices in a lot of our counties, and some of those things that the CDC looked at to compare who's at risk of an HIV outbreak is there a treatment desert? So in many of these northern counties, there are no treatment providers. So that's what happened. We opened in Cadillac of March of 2020, so that's the month COVID hit, right? Did we slow down? No. We opened our door that month, and to answer another question, we really expected there to be a lot of people clamoring for syringe service programs in that community. 4 to 1, people came to us for treatment. We, as an organization, provide outpatient treatment. We provide medication for opiate use disorder out of our office. We also treat hepatitis C in our office. So when people come to us for their doctor's appointment, they also get treated for hepatitis C if they've tested positive for that. And so I was stunned, frankly. Even to this day, for the Cadillac location, I get 4 to 1 phone calls for people who are seeking treatment to get out of their opiate use disorder. And so it's really a center that's providing information and tools to help people along their path. What we also know is, like any human being changing behavior, when people can come to the understanding of how and why they're doing what they're doing, changing at their own pace can be really helpful. It's like, we know that people don't quit smoking cigarettes unless they've tried any number of times, that oftentimes it's not the first time that somebody tries to quit that they actually succeed in quitting, right? And so what we're there to do is to help people with information. Just be careful that when you're going out today, do you have naloxone? Do your friends and family have naloxone? Do they know how to use it? You do realize that even in cocaine these days, there's a lot of fentanyl. So if you're buying cocaine, Traverse City, lots of weddings go on there. It was interesting because we have a lot of the naloxone boxes, the newspaper boxes, and we saw a lot of naloxone go out of the boxes this summer that were going back downstate to communities downstate because people come up to the northern region for weddings, and our message was, we had bar owners who wanted to put fentanyl test strips on their bars because they would have wedding parties come in, they're partying, and a lot of the people who might be partying and some cocaine might be in a part of that party, they may not even be aware that they're at risk of an opiate overdose because they may not have this information, and people need to be knowledgeable about these things. And so that's a lot of what programs like Steve's program and Linda's program and our program does. Education, helping people understand that you may not have ever used opiates, but you need to know why you could be at risk of an opiate overdose. If you're dibbling and dabbling, even snorting cocaine at just a wedding party on a weekend, you could be at risk. We know in April there were 18 overdoses in the county of Kalamazoo, and it was cocaine. Medical examiner tracked it down, and it was people who had unwittingly used cocaine that was that had fentanyl in it, didn't probably even know they needed to have naloxone. So this is a lot of what harm reduction programs do. It's not just about the needle. The unfortunate part, and that I really think this legislation is critically important for, is when the state of Michigan started to really expand syringe service programs, the detail they didn't include was when people bring back syringes, they hadn't expanded legislation to cover the people who were returning used syringes. We found this out from somebody who was anticipating the opening of our Cadillac program. He'd gotten stopped by a state police officer, needle found in his vehicle. He was a person who'd already been to prison on some charges, and he ended up with a new charge from the residue in that syringe. The syringe didn't come from our program. It was before our program opened, but I was frankly kind of stunned to find out that we were being encouraged to expand these programs, but yet there was no participle in the language that covered people returning the used syringes to these programs. It's really important. Like you said, Rep. Schmaltz, we don't want syringes out in communities and parks. And this is a way. I used to work for a very large program in Chicago. We cleaned up the streets because people were bringing back syringes. And so we've developed an incentive program at our Cadillac office so people get little benefits by bringing back more syringes, say a gas card, say a food card, those kinds of things. And so they're really programs that encourage people to be responsible citizens. It's empowering people to feel like they're doing good things for their community, and they're helping clean up things, and we really do a lot more than syringes. We do treatment, hepatitis C care, bloodborne pathogen testing, and Rep. Vanderwall can talk about all the things that he saw at our organization. But thank you very much for hearing us out today.
Thank you very much, Pam. We appreciate you being here. Next, we have Kim Gannon, who is a PhD candidate from Yale University, and their School of Public Health, and she's online.
Yes, hi. I'm coming from Connecticut this morning.
Good morning.
Thank you, Madam Chair and members of the subcommittee. So my name's Kim Gannon. I come to you today as a person in long-term recovery, a PhD candidate at the Yale University School of Public Health, a proud Michigan State alumna, and somebody who calls Michigan home. I first found recovery through the Lansing, Michigan 12-step community in 2015. They were willing to meet me at my worst, exactly where I was. They helped me graduate from Michigan State and eventually pursue my health policy PhD, studying policies like syringe service programs that kept my people alive. Now, with over 8 years of continuous sobriety and a Yale education, I am living proof that no life should be neglected. The research supporting SSPs have spanned 4 decades. In urban and rural communities alike, SSPs have proven to be powerful, life-saving tools. Somebody was asking for statistics, and I know in Michigan it's between 50 and 60%, but I'll call your attention to the unexpected HIV outbreak in Scott County, Indiana, where there was no SSP in place to proactively county it. Scott County, a very rural county in Indiana. Researchers suggest that up to 97% of infections during that outbreak could have been prevented had there been an SSP in place early enough. This number alone illustrates their incredible potential. Both at the time of the outbreak and now, in fact, Trump-appointed Surgeon General Jerome Adams was instrumental in advocating for them. And this says nothing on the return of investment in one city, over $243 million. Reduced syringe litter. I think it was Representative Schmaltz. It's a little hard to see on Zoom. There was a study that came out that in 24 cities across California, the rate at which people engaged in SSPs disposed of their syringes unsafely dropped by 49%. And then, of course, reversal of overdoses and increased treatment entry odds of up to, I've seen numbers as high as 88% among SSP clients. All the while, the vast majority of evidence demonstrates that there's no increase in drug use or crime. So again, hard to see, but I know somebody had asked a question about, are there statistics on people who have come to use SSPs and then later died of whatever what's the word I'm looking for, equipment that they used. I can say as somebody who's coming up in this field that that number isn't collected, because the general consensus and general understanding is that if that syringe didn't come from an SSP, it would have come from somewhere else. It's not the syringe that's causing the problem. It's not the syringe that causes the overdose. So HB 5178, which I'm spending most of my time talking about today, though I will go on record as saying supporting 5179 as well. It outlines a much needed legal process under which SSPs and their clients can operate without fear of legal action. Moreover, it provides crucial language that protects what we call second and third party distribution. This model, which allows not only volunteers and employees of SSPs, but also clients themselves, among others, to distribute materials to their peers beyond SSP walls, are so well supported by research that both the CDC and the National Institute of Drug Abuse consider them best practices. One of the best examples, and Pam, I'm wondering if this is where you worked, one of the best examples in this country actually comes from our own backyard. It's called the Chicago Recovery Alliance. What makes Chicago's program successful, according to the extensive research done on it, is the measures that it takes to remove barriers to obtaining clean, safer equipment. These measures include the allowance of this second and third party distribution, no limit on the amount of equipment that can be obtained at any one time, and meaningful engagement of SSP clients in program operation. Research on the Chicago program and programs like it underscore the importance of including specific language that protects these best practices. Without them, SSPs can't nearly realize the positive potential that they could otherwise. To conclude, the consensus among researchers in this field is that SSPs prevent overdose death and infectious disease without increasing drug use, crime, nor syringe litter. They offer tremendous benefit in terms of both life and cost effectiveness. I repeat, without evidence of increased drug use, crime, and syringe litter. As a researcher, this alone makes HB 5178 worth it, but as a person born out of Michigan recovery, it means so much more. It means that at 28 years old, I may not have to continuously wake up to the news that yet another loved one has died a death that could have been prevented. Thank you so much.
Thank you very much. And now we have Dr. Kara Poland, who's also on Zoom with us. She is a board member of the American Society of Addiction Medicine. Good morning.
Good morning. Thank you so much for having me. I did submit, in addition to the testimony today, some written testimony as well. I think the best way for me to proceed is to support a lot of what has already been said in terms of syringe programs. So House Bill 5178. What these programs do is a crucial public health service, and is as has been mentioned, a large component of the holistic response to the opioid overdose epidemic. But in addition to that, they're an entry point for treatment. And they're sort of, how I often explain them is they're like healthcare adjacent. They're a safe space that allows for people to come and receive services in a non-judgmental environment. And as Pam mentioned in her testimony, they are known to be an entry point to kind of access the mainstream healthcare. As a mainstream healthcare provider, I can tell you that I do a lot of training around preventing stigma in the healthcare system. So for many people who are actively using drugs, the healthcare system is not perceived as a safe place. And so these syringe programs can often act as a conduit, because people will go to them and say, who is a safe provider for people who use drugs, whether that's because they currently have an abscess and they need acute treatment, or for a complication of injection drug use, or if they need, or if they're ready to engage in active care for their substance use disorder. There was some mention of the decrease in risk of hepatitis C and HIV, and I just want to point out that treating as each prevented case of hepatitis C using safe syringe programs saves insurers, including public insurers like Medicaid, an average of over $300,000 per case prevented. So that 50% reduction has been multiple millions of dollars in saved costs for our state that can be used for other programming, or more importantly, I would encourage the legislature to consider, as we implement treatment programs, as we implement some of these cost-saving measures, that we keep in mind on the fact that the money saved needs to be reinvested in addiction care, including things like safe syringe programs. So I'm obviously happy to answer any questions about that. And I do want to point out that the Grand Rapids Red Project is after the Chicago program. It is the largest harm reduction organization in the entire Midwest. So we are extremely fortunate to have their expertise and their commitment to also helping to train other syringe programs throughout the state. And so we do have a resource also, if this legislature goes through, to help support the communities as they start building and truly a nationally recognized leader in the safe syringe in the entire harm reduction field. Regarding House Bill 5179, which declassifying some of the drug paraphernalia, as has been mentioned, really helps us create a safer community. One of the questions, and I know this has been discussed previously, but having access to safer use supplies, whether that's the fentanyl test strips or safer syringes or sterile water, really helps reduce the secondary risks of substance use. There's no evidence that things like Narcan, safe syringes, or fentanyl test strips or other kind of harm reduction tools increase people's risk of using. There's a myth, and it's not accurate, that if we provide fentanyl test strips or we provide naloxone, that people will use more because they have that safety net. And truly, the evidence does not show that to be accurate. So I wanted to point out that the research just isn't there. That's really coming from a point of judgment and stigma toward persons who use substances. And we would never tell somebody who has diabetes that they can't have access to blood sugar test strips, even if they are not in a period of time in their life when they're ready to actively engage in some of the diet and lifestyle modifications that we know are necessary for their longitudinal health and wellness. And so this is kind of similar to that in terms of keeping people safe, keeping people engaged, so they have that access point, so that if and when they're ready to enter treatment, we're there and ready with open arms, and they know that they're going to a safe treatment provider. So the Michigan Society of Addiction Medicine is proud to support evidence-based measures to address the ongoing overdose epidemic. So we do urge lawmakers to support the enactment of House Bill 5178 and House Bill 5179. I end everything that I do with to all the people who have lost their lives to addiction and mental health, and to those that are here trying to prevent further losses. My brother died of a self-inflicted gunshot wound related to his substance use disorder. And so I really commend the committee for taking these bills on and taking them so seriously, and the thoughtful discussion that I've heard so far this morning. Thank you.
Thank you so much, Dr. Poland, and I'm so sorry to hear about your brother. Thank you for sharing that and for your testimony this morning. Finally, we have Judge Linda Davis, who is the founder of Families Against Narcotics. Judge, we're kind of pushing the time here, and there's another committee in here afterwards. would you mind keeping your testimony to a couple of minutes?
Okay, very
Thank
good.
you so much. I really
a
appreciate
lot of
it.
what I would have said has already been
Sure.
said anyhow. There's an advantage to going last because you've already been very educated, but there's also a disadvantage because I bring a personal perspective to this. I think it's important for you to understand that I come from a law enforcement background. I was a prosecutor and a judge. I worked with police officers most of my life, and I had a lot of the same stigmas that they had when I entered this field. And unfortunately for us, it was a family member's addiction that really got me educated about addiction and how we treat it so differently than we do other diseases. And so I've done a complete 180. I will tell you that I met Pam Lynch when I first started my endeavors to educate our community about substance use disorder, and I thought what she was doing was crazy. You know, that what are you doing handing out syringes to people? My law enforcement background got in the way of that, and I thought the same of Steve, and both of them have been so incredibly helpful to getting us up and running as a very viable SSP in the state of Michigan. We would have not been able to start our SSP without Steve. So it mirrors, and those are the things Pam mentioned, the side effects, the residual effects of these programs. SSPs get it right. They are the most cooperative people across the state of Michigan that do work together to make sure that no one slips through the cracks. And they really are a mirror image of what addiction services across the state of Michigan should look like. So I really wanted to reiterate that. I will tell you that when my team came to me and said they wanted to start harm reduction measures in FAN, I cringed. I was not sure that it would work, but like everything else in our organization, they proved me wrong, and I'm glad that they did. We've only been up and running for about a year and a half now, and we do pass out Narcan through all of our programs, and we do all of our programs. So even though our harm reduction program is only on one corner that sets on a borderline between Detroit and Macomb County, we service people from both areas. I know that diversity is an important issue to you. These are the programs that hit diversity at the heart. We are really able to serve the homeless population, the underserved population, the population that is of mixed color. We are there on the streets with them, and they readily come to seek help. It is also true that they are 5 times more likely to seek recovery services. But I just want to reiterate to you, recovery starts with the first conversation. And that's why SSPs are so important. If we can get people that are in the midst of their addiction to come to an SSP, and we are able to talk to them, and most SSPs are being run by people who have lived experiences themselves, and they see them living healthy, productive lives, and that they can do good with a disease that has really crushed their hope and their goals of a brighter tomorrow. And they see that those hopes are really there, that there is help, that you can get through this disease, and that you can be a successful member of our society without using those drugs. It is that first conversation that oftentimes helps them. I know that you told me to limit my testimony, and I'm going to do that, but I'd like to end with one story of something that happened at our SSP site that I just thought really highlights the necessity for these organizations to be able to, without fear, continue to do the work that we do. When I was a judge, I ran a very successful drug court and I had a young man that came into my drug court that had been using substances since he was 12 years old. He really had no family support, and I really didn't think I was going to be able to help him, and he proved me right, but only because he failed to stay. About a month into the program, he decided to no longer come to the program, and we never were able to find out what happened to him. So we did our issue a bench warrant routine and let it go. And lo and behold, that young man showed up at our SSP site, and he had been injecting unsafely into his neck and had acquired a very large abscess on his neck. He did not want to go to a hospital because of how the stigma of addiction is treated there. He always felt very shamed every time that he went in for medical help. So he decided to come to our SSP because we have medical people on board. We partner with the Michigan Osteopathic School, and we have residents from McLaren that work with us out on our site. And so he came to our site. We called one of our doctors because this sore was wicked looking, and we knew it was something none of us should be touching. They transported him. They convinced him they would treat him respectfully. They transported him to a hospital. They did all kinds of work on his neck, got rid of the infection. And I just saw this young man about a week and a half ago, and he is celebrating 1 year and 3 months of sobriety as a result of that SSP being there. He said it was the care, the love, the consideration, the lack of judgment, and the compassion that really brought him to want recovery services. And he lives a very productive life, has a job for the first time in his life, and is very, very appreciative of the fact that we had a van that started his journey to recovery. I could share hundreds of stories like that, and I agree with everything that's been said by my incredible colleagues in SSP world, that this reduces death. We are in the midst of a crisis, an epidemic, and we use those words so loosely when we talk about addiction. But when you think about the fact that we lose, like a jetliner, their largest jetliner, full of people every single day in the United States, and we are still putting up roadblocks to help people live productive, healthy, safe lives. We need to really take a look at that and question what we're trying to accomplish by putting these roadblocks up. I did have a video that I sent to be played that's really a very practical video that shows an SSP live and on work. If there's not time to do that, I would just ask that you take time on your own to watch the video. I think sometimes we have a perception of what an SSP looks like, and it's really nice to know that really responsible people are running these programs that are really trying to do amazing work in their communities. Thank you.
Thank you, Judge. We really appreciate it. We will make sure that everyone on the committee gets the video, since we are pushing up against time, but we'll make sure that everyone gets that. Colleagues, I would encourage you to watch that video. What questions do you have for folks? Okay, Rep. Rankins.
I just want to say that Rep. Thompson on Zoom has a question.
She's not there.
Pass.
Anyone else? And one of the things, and Pam, you mentioned this, you were talking about smoking and folks coming to, for assistance, and just being the kind of the constant. I mean, one of the things that we know in terms of stages of change, that folks are at different places, right, at different times. And when there is that constant place that folks can go, sometimes it can be, I've watched it happen, right? Sometimes there can be that sliver of glimmer, and you need to catch people right in that moment, because they've been, going back and forth and going through these stages of change, and sometimes that window can be small. And so knowing that, just the importance of your programs and the continuity that they provide for folks is so important. Colleagues, I just, because Pam mentioned this, I mean, it can take, I think it's on average like between 9 and 11 times for folks to stop smoking before they're actually successful. And so this is hard, right? Like, this is hard to do. And it's not because people don't want to a lot of times, right? Like, that's not, I know that narrative is out there. And so I think that the role that you play in terms of the net that we create for folks is so important and vital, because, again, like I mentioned, the consistency that you provide and the relationships that are built and the trust that comes from those relationships helps people along through those stages of change. And so I'm grateful that you all are here and that you're working with folks in our communities day in and day out. I just think it is such important work. Anybody else? Okay, so thank you so much. We really appreciate it. We have a couple housekeeping things, folks. First, I'm going to read in some cards. These are from folks who don't wish to speak but are in support. So in support of both 5178 and 5179, we have Mid-State Health Network, Sacred Heart Rehabilitation Center, Oakland County Harm Reduction Program, the HIV and AIDS Alliance of Michigan. We have, in support of all four bills, Michigan Association for Local Public Health. We have the cards for all of our the folks who've testified, and then our clerk has gotten a stack full of electronic cards that will be put into the record so that folks know. The majority are in support of these programs, but we're not going to read all those in because there literally is a huge stack. So thank you to everyone who has given their feedback to us. We really appreciate it, and it will be noted publicly. Rep. McDonald, if you would be so willing to excuse absent members. I appreciate that. Colleagues, anything else before we adjourn today? Okay, yes, Rep. Reagans.
I understand that there's been a ton of written testimony submitted too, so I'm hoping my colleagues can join me in doing some homework and reading through all of those written testimonies as well.
We'll make sure that both the written testimony and the video get out to all the members. Yep, no problem. Okay. Team, thanks so much. There being no further business before committee, the committee stands adjourned. Thanks, everyone. Have good days.